It's time for another warm-up review. Let's get going. Which cytokine, more than any other, should be known as the macrophage activating cytokine? That's going to be interferon gamma. Next, which complement is responsible for neutrophil chemotaxis? That's going to be complement C5a. Next, which pupillary sign suggests a diagnosis of syphilis? Remember, that's going to be the Argyll-Robertson pupil. This is the pupil that is not reactive to light, but constricts with accommodation. All right, that brings us to the end of the warm-up. Let's get to that lecture now.
In this video, we're going to talk about diseases that affect the eye, both intrinsic eye diseases like glaucoma and cataracts, and also the ocular manifestations of systemic diseases. We're going to start at the anterior part of the eye and then work our way back to the retina and the optic nerve. So let's start with a quick review of eye anatomy. So the white part of the eye is called the sclera, which is like the hard shell that surrounds and protects all the delicate structures within the eye. And actually, the anterior sclera is covered by an epithelial layer called the conjunctiva, which produces mucus and tears to lubricate the surface of the eye. Then the cornea is this clear dome that lets the light in. It's not actually the same color as the sclera, despite what it looks like on this drawing. Now, the colored part of the eye is the iris, and the iris has muscles that can dilate or constrict the pupil to regulate how much light comes in. And behind the iris, you have the lens, which can also change shape because it's attached to the ciliary muscles and the ciliary bodies. So the lens changes shape in order to focus your vision near or far. And what do we call that focusing process? Accommodation. Now, if you were to pop the eye out of its socket and then peel off the sclera, kind of like peeling a grape, you'd be looking at the uvea, which comes from the word uva, which is the Latin word for grape. So the uvea consists of the iris and the ciliary apparatus and the choroid, which is this vascular layer posterior to the retina. So all this light brown stuff would be considered the uvea. We're going to talk about the uveitis and problems that uveitis can cause in a little bit. Now, behind the lens, you have this big blob of jelly-like substance, which is called the vitreous humor, or the vitreous body. And then at the back of the eye, you have the retina, which contains the photoreceptors that are responsible for picking up the light signal that's been focused on the retina by the cornea and by the lens. And then the retina is going to send that visual information to the optic nerve. Now, you also need to be aware of the chambers of the eye. The space anterior to the iris is called the anterior chamber. And the space posterior to the iris, but anterior to the lens, is called the posterior chamber. So the posterior chamber of the eye is not actually in the posterior part of the eye. Be aware of that. Now let's start working our way through these various eye pathologies, starting anteriorly and working our way backwards. The most superficial part of the anterior eye is the conjunctiva. The conjunctiva is very vascular, but usually the conjunctival capillaries aren't visible. When you get allergies or an infection and you get some inflammation of the conjunctiva, those capillaries become engorged and they become visible so that the eye looks pink or red. So this child has conjunctivitis in the right eye. Now, most of the time this is a viral infection. For instance, adenovirus can cause this. But if it's unilateral and it's associated with some purulent discharge, which you kind of see caked up in the eyelashes here, that's potentially bacterial conjunctivitis. And as I mentioned, allergic conjunctivitis often goes along with allergic rhinitis in the spring or the fall. Now, what's going on in the left eye? Well, this is another cause of red eye. This is a subconjunctival hemorrhage. So the conjunctiva bled a little bit, and the blood is kind of trapped between the conjunctiva and the sclera. It looks really nasty, but it's completely benign, and it resolves on its own. Now, what's going on here? Well, this patient has elevated bilirubin and jaundice, maybe from hemolysis or from liver disease or obstruction of the biliary tract. You're often going to hear this called scleral icterus because it looks like the sclera is yellowed and jaundiced. But the name scleral icterus is really a misnomer because the excess bilirubin is actually deposited in the conjunctiva, not in the sclera. Next, let's discuss some pathologies of the cornea. The cornea is the clear dome that sits over the colored part of the eye and lets light pass through. Now, the shape of the cornea is very important for refracting light, even before that light gets to the lens. When you do LASIK surgery, you're reshaping the surface of the cornea with a laser and changing the refractive properties of the cornea. One of the most common findings of the cornea is called arcus senilis, which is this whitish or bluish ring at the periphery of the cornea due to the accumulation of cholesterol. And as you can guess from the name arcus senilis, this is a finding seen in older individuals. You can see clouding of the cornea in mucopolysaccharidoses like Hurler syndrome, and you can get corneal abrasions or scratches on the cornea from eye trauma, and corneal abrasions are extremely painful. Once you pass through the cornea and the anterior chamber, you reach the iris, or the colored part of the eye. And we said that the iris was part of the uvea, which is that vascular layer that's sandwiched between the sclera on the outside and the retina on the inside. And when the uvea becomes inflamed or infected, that's called uveitis. Now, sometimes this is anterior uveitis or iritis, which causes pain and redness of the iris, and that redness often extends into the conjunctiva as well. There can be photophobia or light sensitivity, and you can sometimes see pus or inflammatory cells in the anterior chamber, kind of pooling up inside the cornea. Anterior uveitis is commonly seen in seronegative spondyloarthropathies like reactive arthritis or ankylosing spondylitis, and those are both associated with the HLA-B27 genotype. You can also see anterior uveitis with sarcoidosis or juvenile idiopathic arthritis and various other systemic inflammatory diseases. And then the posterior part of the uveal tract, behind the retina, in the back of the eye, is called the choroid. And if you get inflammation and infection back there, it's called posterior uveitis or chorioretinitis, if it involves the adjacent retina as well. Posterior uveitis is much less common than anterior uveitis, and posterior uveitis tends to be more infectious, things like CMV and toxoplasma and cat scratch disease caused by Bartonella Henselae. And also, psoriatic arthritis and inflammatory bowel disease can cause this, which again, those are HLA-B27 positive seronegative spondyloarthropathies. I want to spend a few minutes talking about glaucoma, which is probably the single highest yield eye disease for step 1. But in order to understand glaucoma, you really need to be familiar with the flow of aqueous humor, which is outlined in the study guide. Remember, the space anterior to the iris is the anterior chamber of the eye, and the space posterior to the iris, between the iris and the lens, is the posterior chamber. And both the anterior and posterior chambers contain a clear fluid called aqueous humor, which carries nutrients to the anterior structures of the eye. Aqueous humor is produced by the epithelium of the ciliary body, and then it flows into the posterior chamber and through the pupil in the middle of the iris into the anterior chamber. And then under normal circumstances, the aqueous humor exits the anterior chamber via the trabecular meshwork, which lies in the angle where the iris meets the sclera. But when something interrupts that normal flow, the intraocular pressure builds up and you get glaucoma. Glaucoma is a condition of elevated intraocular pressure, which eventually causes damage to the optic nerve and can result in permanent blindness. There are two different types of glaucoma. There's open-angle glaucoma, which tends to be chronic and insidious, and there's closed-angle glaucoma, or sometimes it's called angle closure glaucoma or narrow-angle glaucoma. But whatever you call it, angle closure glaucoma is usually acute and it's an emergency. Angle closure glaucoma occurs when the lens pushes forward against the iris, which plugs up the pupil and blocks the flow of aqueous humor from the posterior chamber to the anterior chamber. And when the iris is pushed forward, the angle between the sclera and the iris gets narrower. That's why it's called closed angle or narrow angle glaucoma. But the main problem is thought to be the lens plugging up the pupil. In your study guide, we've listed a few important points about angle closure glaucoma. Again, acute angle closure glaucoma is an emergency. These patients typically present with abrupt onset of eye pain. They can have a frontal headache over the eyebrow and extending to the temple. They can also have nausea and vomiting. And if they look at a light source, they may see colored halos or rainbows around the light. The affected eye is usually red, teary, and angry looking. The cornea may be hazy, and the pupil is often fixed and mid-dilated. If you palpate the eyes gently, the affected eye is harder or firmer than the normal eye because of increased pressure. The goal of treatment is to break the acute attack, often by performing a laser iridotomy, which is where an ophthalmologist uses a laser to create tiny holes in the iris to create channels that allow the aqueous humor to flow from the posterior chamber to the anterior chamber and then into the trabecular meshwork. If there's going to be a delay of more than an hour or so getting the patient to see the ophthalmologist, we use eye drops like timolol and aproclonidine to lower the intraocular pressure, and possibly we even use systemic acetazolamide or mannitol. We'll talk more about glaucoma drugs in just a moment. So that's closed-angle glaucoma. Now in open-angle glaucoma, the angle remains wide open. The lens isn't bumping up against the iris and plugging up the pupil. The problem in open-angle glaucoma is that the trabecular meshwork has lost its permeability for some reason, kind of like the oil filter in your car getting clogged up. Open-angle glaucoma is much more common than angle closure glaucoma, and it usually comes on insidiously over a number of years. It's usually bilateral. Risk factors include being over 40, being African American, family history of glaucoma, myopia, and diabetes. Diabetes can cause lots of different eye problems. In the early stages, these patients are usually asymptomatic, but they do have elevated intraocular pressure. Then later, as the glaucoma progresses and the elevated intraocular pressure does damage to the optic nerve, that results in gradual loss of peripheral vision. And ultimately, it results in permanent blindness if it's left untreated. So it's important to screen patients for glaucoma and catch it early. So how can you screen for glaucoma? Well, there are several different ways to measure the intraocular pressure, which is called tonometry. The air puff test is one you're probably familiar with, where they blow that little puff of air in your eye. You can also examine the fundus of the eye and check the optic cup to disc ratio. So when you look at the fundus with an ophthalmoscope, the big yellow circle is the optic disc, which is the head of the optic nerve. Now the optic cup is the smaller, brighter circle in the center of the optic disc. Normally, the diameter of the optic cup is less than 50% of the diameter of the disc. Now in glaucoma, the optic cup is frequently enlarged, so it's greater than 50% of the diameter of the optic disc. So as you practice looking at patients' fundi, get in the habit of checking this cup to disc ratio. And FYI, students tell us that being able to interpret fundoscopic images like these is very high yield for step 1. Let's talk about the treatment of glaucoma. Closed-angle glaucoma is usually treated with laser surgery because that's an emergency. Open-angle glaucoma is not an emergency. You have a little time to act. So for open-angle glaucoma, we usually treat medically, trying to inhibit production of aqueous humor and improve outflow. Beta blockers and carbonic anhydrase inhibitors like acetazolamide will decrease the production of aqueous humor. The ciliary bodies have a lot of beta adrenergic receptors, and blocking those receptors helps to reduce aqueous production. And then prostaglandins, alpha agonists like aproclonidine, and cholinergic agonists like pilocarpine work by increasing outflow of aqueous humor through the trabecular meshwork. Prostaglandins and beta blocker eye drops are usually first line, and then these other classes of drugs are added as needed. And in some cases, we treat surgically with laser trabeculoplasty, which is where you use a laser to blast some tiny holes in the trabecular meshwork to improve outflow. So it's a little different than the laser iridotomy for closed-angle glaucoma. We've worked our way from the anterior surface of the eye all the way through the iris and the posterior chamber, and now we come to the lens. The main pathology of the lens I want to discuss is cataracts. A cataract is an opacification of the lens. The lens is extremely cellular, but it's supposed to be translucent to let light pass through it and focus the image on the retina. But if the lens becomes opacified, vision is impaired. Cataracts are most commonly seen with advancing age, and they're probably the most common cause of blindness. Somewhere in the ballpark of 4 million cataract surgeries are performed every year in the U.S. That's a lot of cataracts. Besides age, long-term glucocorticoid use can increase the risk of cataracts, and so can tobacco and alcohol use. And also diabetes can cause cataracts. This is a patient with a cataract, and you can see through the pupil that the lens is cloudy and opacified. Cataracts aren't always so prominent and so visible to the naked eye, but they can be. In your study guide, there are a few more details about cataracts. Cataracts are almost always bilateral, but one eye may be worse than the other. Cataracts classically present with slowly progressive, painless loss of vision. Patients typically complain that they're having difficulty driving at night, having difficulty reading road signs or reading fine print. They may have disabling glare in bright sunlight or glare from oncoming headlights when driving at night. And early on, the patient may experience some nearsightedness or second sight, or they were getting farsighted from normal aging and presbyopia, and then as cataracts develop, they start to become nearsighted and they realize they don't need their reading glasses anymore. So that might be a good historical clue. Moving to the back of the eye, let's talk about some disorders that affect the retina, starting with age-related macular degeneration. This pigmented spot is called the macula, which is the central area of the retina that has extra dense cone cells to provide fine central vision for reading and recognizing details like facial features. And if that macula degenerates as you get older, that's called age-related macular degeneration. Macular degeneration causes a loss of central vision, but the peripheral vision remains intact. There are two different forms, dry macular degeneration and wet macular degeneration. In the dry or atrophic form of macular degeneration, cellular debris called drusen accumulates between the retina and the choroid. And this causes a gradual, insidious loss of vision. The second type is wet age-related macular degeneration, which has a more rapid onset and a more rapid progression. This is caused by neovascularization or abnormal blood vessel growth in the choroid, and these fragile new vessels bleed and damage the photoreceptors. Now, one of the major risk factors for macular degeneration is smoking, so you need to counsel these patients to stop smoking. And then treatment includes supplementation with antioxidants such as beta-carotene, vitamin C, lutein, selenium, and zinc. Patients with wet age-related macular degeneration can sometimes be treated with injections of antivascular endothelial growth factor into the vitreous humor, or you can treat with laser therapy.
Now, one other pathology you can see on this image, which has nothing to do with macular degeneration whatsoever, is the presence of these fluffy white things that look a bit like clouds or maybe wisps of cotton. So these are called cotton wool spots, and they suggest the presence of focal areas of retinal ischemia, maybe from diabetes or from hypertension.
In general, diabetes is bad for the retinas. The longer you have diabetes and the more severe the diabetes is, the more likely you are to get something called diabetic retinopathy. Without getting into too much detail, with diabetic retinopathy you can see these hard exudates, which are these well-defined kind of yellowish colored spots. You can also see some flame hemorrhages, and you can see the cotton wool spots, which we saw earlier. And then in proliferative diabetic retinopathy, there's proliferation of these new blood vessels, and this is called neovascularization. And these new vessels are abnormally fragile, so they tend to rupture and bleed and ultimately form some scar tissue. So sometimes they do laser therapy to zap those new vessels so they won't keep proliferating. Another disorder of the retina is called a retinal detachment, which is where the retina literally comes detached from the back of the eye. This could be due to trauma or possibly due to diabetes again. So we've seen that diabetes causes glaucoma, cataracts, now retinopathy and retinal detachment. So it's very important for diabetics to have an annual dilated eye exam to check for any type of problems. Retinal detachment isn't painful because the retina has no pain receptors, but patients experience a sudden onset of flashing lights and floaters followed by a reduction in vision. And obviously this can result in permanent vision loss if the retina isn't surgically reattached in a timely manner. Now on fundoscopic exam, a detached retina has this sort of billowy, wrinkled, somewhat pale appearance in contrast to the smooth, normal retina. Then one last retinal pathology to mention in passing is a retinoblastoma, which is a cancer of the retina, most commonly seen in children. We're going to talk about retinoblastoma in the oncology section, but I want to mention it here since we're talking about the eye. It's pretty easy to recognize on your board exams because it's characterized by the loss of the normal red reflex. Most of the time when you shine a light into the eye, the light bounces off the retina and you see a red reflex. But if you see a white reflex of the retina, especially in a child or an infant, think about retinoblastoma. Let's discuss a couple of pathologies related to the optic nerve. First is papilledema, which is swelling of the optic disc. This is our normal fundus again, and you can see that the optic disc is nice and sharp and well defined. Now, papilledema is where the optic disc becomes sort of swollen and fuzzy and blurry. Now, papilledema isn't a disease. It's a physical exam finding that indicates increased intracranial pressure. Not increased intraocular pressure like with glaucoma, but increased intracranial pressure like from a brain tumor. And remember how the optic nerve has a central artery and vein running right through the middle of it? Well, if that central retinal artery gets occluded, that can cause ischemia of the eye. Central retinal artery occlusion will cause painless vision loss, and then the classic finding on fundoscopic exam is a pale retina with a cherry red spot in the macula. Now the retina has been cut off from its blood supply and it becomes ischemic, which makes it look pale, but in the very center of the macula, the retina is very thin, so the blood vessels in the choroid behind the macula are still visible, and that causes this cherry red spot. So what else can cause a cherry red spot on the retina? Well, you can see it with central retinal artery occlusion, Tay-Sachs disease, Niemann-Pick disease, and other lysosomal storage disorders. These will also cause a cherry red spot by different mechanisms. In lysosomal storage disorders, you have abnormal substances accumulate in the ganglion cells of the macula and make it look red. And while we're discussing weird eye pathologies, I want to throw in a couple of brain lesions that affect the eye. The frontal eye fields are part of the frontal lobe of the brain, which controls scanning eye movements, which allow the brain to map whatever you're paying attention to. A lesion of the frontal eye field on one side will cause the eyes to deviate toward the side of the lesion. So a lesion in the right frontal eye field will cause the eyes to deviate to the right toward the lesion. Now contrast that with a lesion to the PPRF, or the paramedian pontine reticular formation. The PPRF is a brainstem structure rather than a cortical structure that's also involved in those scanning eye movements. And a lesion of the PPRF will cause the eyes to deviate away from the side of the lesion. There's another deep brain structure called the superior colliculus that's involved in eye movements, among other things. But a superior colliculus lesion will cause paralysis of upward gaze so that the eyes tend to look downward. This is referred to as Parinaud syndrome. Now, one student suggested that you can remember this by thinking of a nerd who is superior at calculus, but he's socially awkward and he's always looking at his feet. So he's superior at calculus, that reminds me of the superior colliculus, and he's looking at his feet, so his eyes tend to look downward. You can even change paranoid syndrome to paranerd syndrome if you like. So now it's time for the end of session quiz. So I want you to pause the video and answer the questions, then we'll go through them together. First question, what initial type of vision loss is commonly seen in patients with open-angle glaucoma? Permanent peripheral vision loss, which can eventually progress to central vision loss. So if you see a visual field with peripheral vision loss but preserved central vision, like tunnel vision, think about glaucoma. Next, what drug classes are used in the treatment of glaucoma? Prostaglandins and beta blockers are first line. We also use alpha agonists, carbonic anhydrase inhibitors like acetazolamide, and cholinergic drugs like pilocarpine. And in acute angle closure glaucoma, we use osmotic diuretics like mannitol to lower that intraocular pressure rapidly. Last question, what's the treatment for dry, age-related macular degeneration? We talked about smoking cessation and then daily supplementation with antioxidant vitamins. That's it for now. I'll see you next time.